Okay, perfect. So we're ready to start. Good morning, afternoon, evening, everybody, depending on where you are. Thank you for being here today. And thank you for joining us for today's panel, Amuse-bouche, the Lancet Commission on Cancer and Health Systems, where we will explore how addressing cancer's unique challenges can ultimately strengthen health systems worldwide. I will just stop sharing that slide. And first, I want to begin saying, unfortunately, Dr. Patricia Garcia, who was originally scheduled to moderate today's panel, is experiencing a respiratory infection, so she won't be able to lead this session. However, she's joining us today. Thank you for that, Dr. Patty. And I will be introducing the panel on her behalf. Before we begin, we would like to express our heartfelt gratitude to the organizers of the London Global Cancer Week for their commitment on advancing the conversation on cancer control and for providing this space for collaboration and shared learning. Please note that this session will be recorded and published for on-demand viewing in the London Global Cancer Week Watch Games section and on our Lancet Commission website. I am Dr. Marcela Gil. I'm a member of the Secretariat and an early career researcher of the Lancet Commission on Cancer and Health Systems, and it's my pleasure to introduce today's sessions. Today, we are joined by Dr. Mary Gospodarowicz, Professor of Radiation Oncology at the University of Toronto. Is the former director of the Princess Margaret Cancer Center in Toronto, and a former regional vice president of Cancer Care Ontario. Currently, she is working on global cancer control, global access to radiotherapy, and quality cancer care. She is also a past president of the Union for International Cancer Control, UICC, and current member of the board of directors of City Cancer Challenge Foundation. She's also the co-chair at our Lancet Commission on Cancer and Health Systems and the Lancet Oncology Commission on Cancer in the Commonwealth. Joining her is Dr. C.S. Pramesh, Director of Tata Memorial Hospital in Mumbai and convener of the National Cancer Grid, a unique initiative linking more than 300 cancer centers to improve and standardize cancer care across India. Dr. Pramesh, a thoracic surgeon and renowned researcher, has spearheaded studies on cost-effective cancer treatment and evidence-based care models. His efforts focus on bridging gaps in cancer treatment and advocating for comprehensive cancer care strategy in low and middle-income countries. Finally, Dr. Felicia Merino of University of Miami. She is a full member of the Cancer Control Program at Sylvester Comprehensive Cancer Center and directs the Institute for Advanced Study of the Americas. Her career was centered on addressing inequities in global health, with particular focus in Latin America and Caribbean. As someone who has lived with breast cancer, Dr. Knowles brings a personal perspective to her advocacy for cancer patients, especially regarding palliative care access and health system strengthening. She's also the founding president of Tómate lo Pecho, a Mexico-based NGO that has promoted research, advocacy, awareness, and early detection of breast cancer since its inception, and which has now expanded its mandate to include women's health and health system strengthening. With that, let's begin. We look forward to a thoughtful and inspiring discussion. And now I will hand it over to Mary for her presentation. Thank you for being here.
Thank you, Marcela. Let me try to share my screen. Can you see my slides?
Yes,
perfectly.
So thank you all for joining us for this Amuse-bouche or tasting menu, where we will share just a few ideas from the deliberation of our Lancet Commission. Our scope is global cancer control, and by cancer control, I mean programs that to lower the risk of cancer in the population, prevent cancer, screen, detect early, secure access to timely, high-quality diagnosis and treatment, provide supportive care and palliation, as well as rehabilitation and survivorship care. To do that, we need a robust cancer control system, fully integrated and effective health system. We postulated also that the evolution of a comprehensive cancer system that meets the full patient needs will naturally strengthen the health systems because, as I show, of complexity of cancer. And this is not a commission on cancer in low and middle income countries. We have debated and continue to debate how to raise the bar for cancer control everywhere. Since at the present time, no country has a perfect cancer control system that meets the need of all segments of the population. This is our charge. So why cancer? Well, first of all, because it's a huge problem. It's a leading cause of premature death in the world, in huge parts of the world. It is also a leading cause of illness, and this graph shows the projected number of new cancer cases that are projected to occur in the world by 2040. Because with the population growth and improved life expectancy, the numbers of new cancer cases are growing and will continue to grow. We are, however, quite fortunate to have tools to cure cancer and improve survival. And this study from actually UK shows that between 1970 and 2000, the long-term survival, the 10-year survival of patients with cancer has doubled. And we are continuing to see the advances in cancer with the increasing rate of progress in cancer drug development. And this slide shows what a tremendous improvement in our tools as far as cancer drugs has occurred in the last 20 years, and the progress is continuing. Similarly, we have witnessed a tremendous progress in computing, imaging, and robotics technology, and this very complex slide shows the evolution of radiotherapy in the last 40 years, the evolution that is continuous and will continue with improvements in technology. To achieve the best outcomes in cancer, the patients need to undergo a number of steps in the patient's pathway, from the presentation to diagnosis, to a number of procedures and tests, to treatment and managing adverse effects. And that's a very simplified diagram, which actually looks quite complex, of what patient's pathway is in cancer, just for the one course of treatment. But in order to achieve all those steps, the patient can have many potential interactions within health system factors. And this very complex slide shows what needs to be in place in order to achieve this optimal outcome for patients, with many, many different healthcare professional groups, many products and technologies, many service delivery points, and so on. About 5 years ago, the National Academy of Medicine has published this wonderful case for cancer control as a complex adaptive system. And they talked about not only complexity of cancer as the disease, but also complexity of the patient population, the complexity of interaction between cancer and the patients, and interaction with public health, population health that occurs in order to meet the needs of cancer control. This document actually called for transformation of our approach to cancer control in order to take advantage of the improvements in the system. And the subject of complex adaptive systems has been increasingly studied, probably mostly in the last 20, 25 years. And There are many examples of complex adaptive systems outside of healthcare, but healthcare itself, health systems, and specifically cancers also qualify. Complexity science is evolving at a very rapid pace. I just put here the graph of the papers in PubMed that have been published in the last 35 years on complexity science. You can see the subject has been not really considered very much until sort of early 2000s. But in the last few years, each year, there are close to 70,000 papers published on complexity science. Clearly a hot subject that needs to be taken seriously. A few years ago now, WHO has published this paper on systems thinking for health systems strengthening. And one of our commissioners, Dr. Julio Frank, is quoted in this paper as presented, quoted for his presentation where he talked about the 4 revolutions that are currently underway that are transforming and will transform health and health systems. And he included in that revolution in life sciences, and I've showed development of cancer drugs and cancer information, revolution in information and communication technology, revolution in our expectations for social justice and equity in healthcare. And the final one that I want to bring your attention to is systems thinking to transcend complexity. And the reason why we need system thinking is well illustrated by this cartoon of the blind people trying to detect and touch the elephant. And depending on the part of the body of elephant they touch, they have different conclusion what is the subject there. If the trunk is a snake, the body of elephant is a wall, the tail is a rope. It just shows you that if you only look at one segment of the problem, you don't see it as a whole. And the field of system thinking has been put forward by Peter Senge, a professor at Harvard, who included this as a 5th discipline in order to improve the performance and practice of organizations. He started the concept of learning organization, which is organization that can continuously improve and take advantage of innovation. And to quote him, he said that business and human endeavors are systems. However, we tend to focus on snapshots of isolated parts of the system. And then we wonder why our deepest problems will never get solved because we don't see the whole. So how do we go from systems approach to cancer control? There's been much written about the need for system approaches by OECD and by other bodies. And the health system is an organization of people, institutions, resources, and processes that deliver the services to meet the needs of the population. And with the complexity of cancer that I've showed and our continuous and rapid progress, we need a systems approach to cancer control. So I tried to very briefly tell you that cancer control is a complex adaptive system with its huge size of the problem, the huge scope of the problem, and also rapid progress in technologies and the changing environment for cancer control. So we need a systems approach as an answer to managing this complexity. A piecemeal, fragmented, simplified linear approach just will not work, and it has not worked. And cancer control is dependent on health systems. And in fact, all countries have some health systems, although they are at the various stages of development. And the question that were posed in the commission is, can we measure the state of development or maturity of those systems? And can we guide the development of cancer control system that meets the needs of people at risk or with cancer to meet their needs? I'd like to finish with my favorite slide. This is a quote from Einstein, who was supposed to say that the problems we have created in the world today will not be solved by the level of thinking that created them. But I like this colloquial interpretation of his quote, which says insanity is doing the same thing over and over again and expecting different results. So our commission is trying to think, how can we do things differently in order to improve global cancer control? And with that, I wanted to thank you for your attention and extend special thanks to David Jaffrey and Pramesh, Felicia, Patricia, Beverly, full secretary, commissioners, advisors, and early cancer researchers, because those were rich discussion for our commission, and I hope you can wait for our findings that should be coming next year. And with that, thank you for your attention, and we'll go straight to Pramesh for his presentation, and we'll take questions at the end. Thank you.
Thank you, Mary and Marcela, for that kind introduction and introducing the concept of the Lancet Commission of Cancer and Health Systems. It's been an absolute privilege to work with this wonderful group over the last almost 3 years, trying to identify what the levers are and how we should look at cancer and health systems as a group. And I'll be speaking about the burden of cancer and how we could potentially look beyond the numbers. And I make this presentation on behalf of the Working Group 1. Just take a minute to acknowledge the enormous contribution that Lynn Denny made for this commission as a whole, and to the Working Group on burden in particular, and our sincere condolences to the family who we lost a few months back earlier this year. So to begin with, why should we measure burden? And I'm probably preaching to the converted here, but it helps us understand the scale of the problem as well as trends related to the problem, particularly with an effort to quantify the extent and scale, as well as understand temporal trends of disease. But what it also does is to acknowledge that burden varies across sexes, across life stages, and is heavily dependent on social determinants of health, geography, and socioeconomic status. So what might be true for a 65-year-old woman with breast cancer in Florida might be very different from a 45-year-old woman with cervical cancer in Burkina Faso. And the other issue with cancer burden is that we need to understand and accept the fact that this will change over time, and we need to be able to adapt to this change in a very nimble manner. Which brings us to the concept that measurement of burden needs not only to be real time, which all of us would expect, but is a dream for vast majorities of the world, but also to enable projections which can then help plan cancer, allocation of cancer resources, which brings us to the second reason why we should measure burden, which is the impact on healthcare resource allocation and policy. We all know that population level planning is required for cancer control, and to help set up these policies, strategies, and plan, unless we have a robust measurement of burden, this is likely to be a suboptimal planning situation. And more importantly, a measurement and a robust way of measuring burden is critical for several other activities, including targeting where our services should be prioritized, setting priorities for every aspect of cancer control, including prevention, diagnosis and staging, treatment, palliation, and survivorship, to estimate workforce requirements. So just to give you an example, if we were to go by what we planned 20 years back as far as workforce requirements are concerned, given the remarkable advances in molecular oncology and molecular diagnostics, we would be woefully short of molecular pathologists and bioinformaticians to guide our treatment decisions. It also is extremely important to estimate infrastructure requirements, because unless you learn or are able to predict or project what your cancer requirements are, infrastructure projection and prediction is going to be extremely difficult. And therefore, it does help guide resource allocation. And finally, it helps us prioritize the areas of research that we should be focusing our attention on. I'll not dwell too much into the economic implications of cancer burden, because Felicia will be dealing with this in a lot more detail. But nevertheless, it's important to understand burden to project what the direct and indirect costs are to the individual, to the healthcare provider, to the system at large, and finally, help guide national budget prioritizations. It also helps us impact on workforce productivity by looking at time off work due to treatment, and the concept of time toxicity is getting increasingly recognized. More importantly, the shortened life expectancy of people with cancer is something that we need to deal with. And any intervention that we do to improve cancer control will, by default, improve workforce productivity. And economic evaluation does need to take this into consideration as well. The impact on healthcare systems is something that I would reiterate, both by way of resource allocation and looking at the relative burden of different diseases. As a policymaker, we need to see where our best bang for our money is going to be. To be able to help balance our resources optimally, and to help project guiding the workforce allocation in a better way. The next aspect of the impact on healthcare systems is on planning for prevention, treatment, and palliation. So, for example, if a lot of the cancer-related burden was related to tobacco, you would necessarily plan your policy and prevention towards tobacco control. Increasingly, we know that stage distribution guides the planning of resources. So if your biggest burden is because most patients present at an advanced stage of disease, which is the reality in most low and middle income countries, a stronger emphasis on prevention without de-emphasizing the importance of treatment would be the approach that we would take. And necessarily, we would need to look at public health interventions depending on the type of cancer that is most prevalent. It has a major impact on policy and public health. Health policy and resource allocation is directly linked to the cancer burden. And increasingly, we realize that data-driven policies will guide funding decisions. And unfortunately, in most parts of the world, the lack of availability of reliable and credible data stands in the way of helping us make these evidence-based decisions. Also, targeted interventions and efficient resource use are more likely to have better outcomes. And again, it comes back to the concept of having a reliable and a robust data supply chain. The role in public health programs cannot be overemphasized, prioritizing prevention programs depending on the prevalence of the disease. For example, smoking cessation for tobacco-related cancers, HPV vaccination where cervical cancer is a major problem are obvious efforts in prevention that we should be emphasizing. And finally, the importance of screening and early detection, depending on where we have strong data to support the major elements of screening. The last two bits that I want to talk about of the importance of measuring burden are on research and on advancing equity. We know that priorities in cancer research are heavily skewed. They're predominantly driven by high-income countries. They're predominantly driven by pharmaceutical companies. They're predominantly driven by systemic therapies, with the result that less than 10% of research that is done currently in the world focuses on surgical research, radiation research, palliative care, and survivorship research. And clearly, this is not a sustainable solution that we should be looking at. And therefore, identifying the burden is an important aspect of resource allocation to make sure that we focus our research priorities on high burden cancers. And finally, but most importantly, to advance equity in cancer care, we need to address the disparities in cancer burden and control that we currently have, and to make sure that we ensure equitable access to prevention and treatment, especially in the vulnerable populations that live in low and middle income countries. So we do have several measures of cancer burden, the traditional measures being incidence, prevalence, survival, and mortality. And these measures do fulfill a necessary requirement that we have. So, for instance, the incidence burden of different cancers across the world gives us a relative importance of where we should be focusing our attention on. We also have mortality data, which again is not so robust as incidence, but still gives us some guidance on where we should be focusing our attention on. But if you look at these two graphs, and if you look at the priorities of cancer research globally, these are completely skewed. A disease which has a 6% mortality has 19% of cancer research investment. A disease which has 20% mortality, 20%, which accounts for 20% of the overall cancer mortality, just receives 8% of the research funding. So again, which demonstrates the fact that we've not been able to align our research priorities depending on even these very crude estimates of burden. More recently, we've had the importance of QALYs and DALYs that have come in on as a measure of cancer burden. But I will argue that there are several challenges in measuring this burden. First, there is lack of data in several parts of the world. Where it's available, the data is unreliable or incomplete. And most importantly, but I'll come to this. So the graph you see on the right is a measure of where you have high quality population-based cancer registries, which effectively is available only in extremely high income countries. And the vast majority of sub-Saharan Africa, majority of Latin America, and in Asia have either low quality population-based registries or do not have any kind of population-based registries. But the final point that I want to emphasize here, and which has been central to our work in the Lancet Commission, has been that even these measures that we have are incomplete and do not give a nuanced version of what the cancer burden truly is. So we thought it's important to go beyond the numbers. And there were some fundamental principles that we thought of. The first be the understanding that measuring cancer burden optimally is critical. And I emphasize the word optimally because the current measures that we have are clearly not fit for purpose. The traditional methods that we have of measuring burden, like incidence, prevalence, mortality, and QALYs, are great, but they're not enough. And they do not encompass the entirety of the concept of burden or its complexity, which Mary very elegantly demonstrated in her previous talk. And most importantly, they do not reflect the outcomes that we need. They do not reflect the importance of burden on individuals, on healthcare providers, or health systems, or in fact, on society as well. They're very skewed in the way they measure burden. Increasingly, defining and describing burden beyond these traditional metrics is being recognized as something that's important. So again, going beyond the numbers, what we felt within our working group was that we needed to be aspirational, be futuristic, and as future-proof as possible, and allow agility in health system responsiveness. The filter that we ran all our measures, which we considered were relevant and important, was that how would these newer methods of measuring burden add value to our efforts towards global cancer control and not just limit ourselves to high-income countries? To understand that burden is a complex issue and the change in outcomes to be measured would be equally complex, but identify possible solutions to address these burdens with some examples as well. So these were the guiding principles on which our working group worked on. My final few slides on what I believe the working group believes will be the future of cancer burden measurement. We do believe that in the next decade or so, we will have wider availability of data and actually an attempt at democratizing the availability of data. And I say this confidently because the adoption of digital health solutions, as well as fairly innovative sources of data like wearables and mobile devices, are expanding globally. And today, we probably have more mobile phones than humans in the world. The advances in AI and data analytics brings in an additional and a very exciting way of how we will be able to gather data. And I must mention here that some members in our working group have actually looked at how we can use AI in mining generative text and coming up with thematic areas where we are able to answer burden as well. And this is something that we are super excited about in bringing to the Lancet Commission. And when the actual publication comes, you'll have more details on this, where we are able to get narratives of patient stories, wherein we are able to get patient-reported outcomes in a way that electronic medical or digital health records have never been able to get. The potential of big data and machine learning in predicting burden trends is something that's likely to expand exponentially over the next decade or so. All of which prompts us to an optimistic approach that rather than being reactive, which is the way the majority of the world has reacted to data and measurement of cancer burden, we will be able to change it to a more proactive method where we're able to project and estimate burden in a much better way and plan much ahead into the future. So in summary, I think we've clearly understood that measuring burden is critical and extremely important and a necessary first step towards global cancer control. The effort of measuring burden has serious impact on healthcare resources, policies, and equity, something that all of us work towards. We also realize that while traditional measures of burden have served their purpose, they are no longer fit for purpose anymore. And newer and more meaningful measures for burden on patients and providers are extremely important. And the sooner we realize the importance of this and identify these measures, the better it is for overall cancer control. And again, coming back to what Mary mentioned in her talk, we have to embrace that fact that measuring burden is complex, but rather than shy away from it, we have to embrace the complexity of measuring burden and ensure that we use modern technical tools like AI and ML to build thematic areas on which to act upon. And AI, ML, and large language models truly have the potential to revolutionize the way we think of data and our concept of cancer burden. Thank you very much for your attention. And I'll take this opportunity to thank our colleagues within our working group, many of whom contributed in a very large way to the presentation that I just made. And a special shout out to Lynn Denny, who's no longer with us, and all the others who are mentioned on this group. Thank you very much for your attention.
Thank you so much, Pramesh. And yeah, Lynn's knowledge and force as a physician, as a health systems leader, and as a patient permeates so much of what we do in this commission, and will continue to do so. And I have the great pleasure of sharing with everybody that, cancer makes people be very generous. So Marcella is generously giving her birthday morning to us because it's her birthday today. So happy birthday, Marcella. It would only be fair to share that, as well as thanking you and thanking the Secretariat. And of course, while I don't have a slide doing so, I want to highlight how grateful I am to my co-chairs, to Mary and to Patti. Patti is smiling but not saying anything, which is a good thing. It's better to smile than not to smile, especially if you're not feeling well. But also to a few people whose contributions you'll see in the slides, but who have really made very important pieces of the work happen and will continue to make those ready for our Lancet Commission report. And those include Beverly Esue and Hector Ariola Ornelas and David Soriano, among others. So many thanks to all of them. And again, to our Secretariat, to Valentina, to all those who are on and listening. Let me now switch over to the slides, if I'm able to. And just, can you confirm that you can see them, Marcella?
Yes, they are good.
Wonderful. So we're going to go through a value approach to investing in cancer and talk about an idea that is permeating the work that we're doing, which is called Towards an Economics of Hope. I want to start with this quote from Muhammad Yunus, a leader in global health and in rights. And Muhammad said, "My greatest challenge has been to change the mindset that plays strange tricks on us. We see things the way our minds have instructed our eyes to see. And that's a lot of how we've seen the costs of cancer. And we're trying to turn that on its head. So we are rethinking the costs and benefits of investing in cancer control, and that will generate, we hope, a new vision for priority setting for cancer, but also for many other areas within health systems. So we're arguing that costs, at least future costs, are lower than we think they will be, and that the benefits are much broader and higher. And when you think about the benefits, and we're going to discuss this in more detail, that the value of acting has to be compared to the cost of inaction. So the benefits are often what are not reaped, but they are there if we think about the alternative of doing nothing, which we believe is not an alternative. And we're going to go through briefly in this presentation some of the ideas and data that underlie that. What happens with an economics of hope? You have an encompassing vision and set of priorities. You go beyond what is the standard cost benefit or effectiveness ratio. And because the benefits, the denominator expands and the numerator is smaller in the future, what happens is that many of the interventions that we think are too costly to afford for cancer and for other areas of the health system, we are able to afford. We also means that the return on investment, the ROI supposedly per dollar invested for any specific intervention is actually lower than the costs are lower, so the return on the investment is actually higher. And that means that even in interventions that we think are highly cost effective, we may be looking at lower bounds, so that $7 for tobacco is actually a low return on investment. It's probably much higher than that if we think in an economics of hope kind of framework. Now let's think first about the costs and how we can rethink the cost, and then how we can harness platforms, global and otherwise, for market shaping. And I know that one of Mary's slides or ideas started with the idea of an elephant, and many of you, I'm hoping, have read The Little Prince by Antoine de Saint-Exupéry, and that people think he was initially drawing a hat, and that's what the adults thought, but inside the hat was actually an elephant, so that you're looking at entirely wrong. Well, if we look at how countries spend on health, we do in fact have an elephant in the room, which is the United States. In these data, with an expected life expectancy of about 79 years, and the spending per capita, which is well over 10,000 in these data compared to many other countries. What I want you to look at, though, is that countries that spend the most are not the most efficient, the US being the outlier, but there are other examples that we can call on, and when we compare it, how much is being spent versus how much is being achieved, you see that spending more doesn't imply that you're spending well. So the idea that everything is more expensive than it really should be is out there, and that's the elephant. This is something that Paul Farmer, may he rest in peace, one of my friends, colleagues, and mentors, hammered home to us when we were first working on cancer well over a decade ago. This is his slide. The cost is too often an excuse for inaction. Paul shared these quotes at the time, but they were people who were leading our health systems. These ideas continue to permeate. In this case, it was things like, in developing countries, people with multi-drug resistant tuberculosis usually die because effective treatment is often impossible. Or it's just too expensive to treat the poor because it detracts attention and resources from other diseases. Now, what he then showed, working with colleagues and others, is that you could cure many people, but also that you could see a very important decline in prices. These are specific prices for MDR-TB, and they dropped 90%, 98%, depending on the particular medicine. Fast forward now to what we see in our world with something like the Global Fund, which is the sort of platform that we require to drive down prices. And by leveraging economies of scales, you see malaria treatment dropping by 36%, ARVs by 50% in relatively short periods of time when there is global collective action to make that happen. Think about something that's a little bit closer to home for cancer, the evolution of the price of the HPV vaccine. It's a combination of the science going to one dose, but also of thinking how how you can have this vaccine in a Pan American Health Organization revolving fund or in a Gavi. And you see this decrease in the number of doses, but also in the price for dose, and hence the cost of preventing this disease. And these are very dramatic reductions. Now, think of yourself as the planner and think that you decided to plan for $360 and 3 doses. Well, you'd be entirely wrong in thinking of how you could distribute this and what it would cost and whether or not you could afford it, because about 15 years later, it's a fraction, less than 10% of that cost. So you have to plan in a very different way. This is an example that we have from our Lancet Commission on Palliative Care and Pain Relief. We estimated the cost of closing the access abyss, primarily in morphine equivalent for palliative care. And we come up with a number that's actually very low, 600 million, but that's not what I want you to focus on. What we looked at is, why do poor countries pay much more than rich countries for the same medicines, particularly for morphine? And it turns out that if you could get poorer countries to access the prices that wealthier countries have, it's less than a quarter of that, 145 million, which is even lower and a tiny amount compared to the price of running any hospital in the United States. So the conundrum here is that those who are most able to afford have the lowest prices. How do we do something about that? Well, I'm not going to tell you what Pramesh is doing, but I am going to tell you that he's doing it. So the National Cancer Grid, and there's a wonderful paper on this in the Bulletin of the World Health Organization, is doing a pooled procurement initiative. I know they recently had their meeting, and a huge savings of 13.2 billion Indian rupees compared to maximum retail prices. And savings range from 23 to 99%, with a median of 82%, and we're more with generics than newly patented medicines. So we actually have national examples of how bringing countries together, in this case, and also hospital-based units together, can achieve a win-win situation with tremendous reductions in price. The last example, St. Jude's. And we're working very closely with St. Jude's Children's Research Hospital and with Carlos Rodriguez Galindo and his team. And he shares with this example of how, through a private hospital in the United States, generating a $200 million fund that is working with UNICEF and with WHO, they'll be able to reach 120,000 children in 50 countries. What they're also going to be able to do is drive down the prices that any particular country or hospital or family would face by being able to aggregate demand and negotiate effectively with producers. So this is what we think about in terms of costs. The bottom line, prices are permeable. The challenge of cancer demands that we do not treat the status quo as a given. We have to plan for a better tomorrow. Taking prices as fixed or given fuels paralysis. It generates often predetermined by the wrong things: politics, discrimination, exclusion, and lack of voice and lack of power to negotiate. We can do something about all of these barriers. So that's the cost part of the equation. Now let's think about a more complete accounting of the benefits of investing in health and specifically in cancer control. I know this takes you way back, but think about a world without a vaccine for polio. The world of the iron lung, the world where polio dominated so many different decisions. We could talk about other diseases that have done this. But why I'm taking you back to that is to say interventions, innovations can change the economies of entire countries and regions. And those are health innovations. And we don't expect them to happen, but when they happen, they ratchet up growth. The second major piece to keep in mind is that people are the backbone of the economics of hope. They're also the backbone of an economy. When we lose a life to cancer because it was too expensive or difficult to treat, we lose all that that person could have generated and would have generated in their lifetime for their area of work, for their families, and for others. This is the example of my mentor, Amartya Sen, who won the Nobel Prize in economics in the 1990s, and who, as some of you will know, suffered and self-diagnosed a serious hard palate cancer that was treated at age 18 in India. Had he not been treated, had he not had access, think of all the world would have lost. This is part of a larger health system strengthening approach that we call the diagonal approach. And that says that rather than focusing on either the disease-specific vertical or horizontal system programs, you harness the synergies. Synergies of diagonal strategies generate major and unmeasured benefits. The key is that we don't measure these. It means that there are these positive externalities or sort of spillover effect that add to the benefit part of what we're talking about. Here's one obvious example, how cancer research helped deliver a COVID-19 vaccine in record time. So the investment in cancer had a huge spillover effect that changed our world. It's a major positive externality that perhaps had not been imagined, but we have to be able to measure this when we think about the value, in this case, of investing in the science. But let's turn to another area, which is how cancer control can support poverty alleviation. A whole other area that we know is extremely important to patients, to their families, to the communities, to countries, and to the economies, or not. And the not is that cost of inaction. Here is some new data. These are preliminary results for Mexico and Peru, largely funded and led from the Tecnológico de Monterrey, Mexico, and we're very grateful to them for supporting this work. What I want you to look at here is how much economic hardship and catastrophic spending we're seeing among cancer patients. And compare this to what we know from national surveys. We're very concerned that nationally, about 2 to 3% of families suffer catastrophic spending every 3 or 4 months. They're driven into poverty, they lose all that they have, and they have what we call financial toxicity. But among patients with cancer, we're looking at prevalence rates that are 20 and 52%. So they're 10 to 30 times as high, depending on what we're looking at in terms of the numbers, than what we're seeing in national surveys or subnational groups. So by not protecting these patients with health insurance, what we are doing is, in fact, forcing much more poverty and much more financial catastrophe. How do families cope? Here are the examples from these same families, these same patients. They stop spending on health. They stop spending on their light. They stop sending their children to school. They reduced their budget, which was already marginal on food. They had to sell their savings or sell assets. They had to ask for loans at incredibly high prices. And often they lost their source of income, either because they themselves had the cancer or because they needed to pull a family member out of the workplace in order to provide them with care. This kind of financial catastrophe may affect what we think are a small number of patients, but it means that they stay in poverty. Yet, when we look at the data that we have, and this is work being done and led by Beverly Esue out of the University of Toronto, we see that we have very little information, particularly from low and middle income countries, on catastrophic spending that is specific to cancer. We are seeing only those national numbers, that 2%, that 3%, which is very significant, but we are not able to understand what the cancer patient is going through and how not investing in cancer control is generating and fueling additional poverty, inequity, and financial catastrophe. Furthermore, we only have a very limited view of what these costs are, as Pramesh mentioned. Most of the studies that we have, in addition to not telling us very much about low and middle income countries and not enough about cancer, talk only about direct medical costs. And this is the last piece that I'll add into the puzzle that we're putting together for our Lancet Commission, which is there are a series of unmeasured areas that are very important costs to patients and to their families, and that is suffering. We think it's an obvious point. I'm sure in London Cancer Week, this is obvious to most of you, but in the economics field, we do not measure the value of alleviating suffering. And that means that we're undervaluing the interventions that we have for cancer and the investment that we make on cancer. These are data on what we call willingness to pay. They are preliminary results, but in Mexico, they were willing to pay 6 times their monthly household income just to solve the practical problems, for example, of transport. And in Peru, 3 times their monthly income to be able to alleviate some of the physical, emotional suffering, as well as the practical concerns. For patients, this is hugely valuable, extremely important, and we are not measuring it. I'll close with this quote from Helen Keller, and I think it talks about why an economics of hope is needed to change our mindset and vision, to see that elephant in the room and to do something about it because we know how. And she said, hope sees the invisible, feels the intangible, and achieves the impossible. And as Marcella mentioned, I say this as a patient. This is me in January of 2008 with the same child, age 3, my daughter, and me in the summer of 2008. There is so much hope that we can inject into work on cancer, and we believe that that will help us to change the way we think about health systems. Thank you very much.
Thank you all for your enriching presentation. And now we have a couple of questions from the participants to start with the Q&A. And I would like to start with Tatiana. First, thank you for sharing part of your awesome experience. She highlights a key gap in cancer control compared to HIV and TB programs, the lack of specific monitoring indicators. She mentioned that while HIV programs are facilitated-based metrics, for example, patient-treated, diagnosis, biopsy, cancer control efforts often focus, as Dr. Pramesh mentioned, only on broader indicators like incidence and mortality. So Tatiana asked if similar facility-based indicators can be developed for cancer control programs to improve monitoring.
I don't know whether Pramesh, you want to address that?
Sure, I'll take a first stab at that, and maybe Felicia and Mary can chip in as well. I think one of the fundamental elements that we recognized in our working group was the fact that the existing measures of burden are clearly not fit for purpose, nor are they nuanced enough to look at the burden in a holistic way. Most importantly, they look at it purely from a policy or to some extent a healthcare provider perspective, but very little from a patient perspective or a people perspective. And that's something that we need to change. And looking at patient-reported outcomes, measures like financial toxicity, time toxicity, are things that are increasingly getting recognized as important measures of burden. But I still think there's a long way to go before we actually identify those as important measures, and importantly, start measuring them, because as we do that, the richness of the data that we will have will guide our predictions and projections for the future.
I can chime in. We've had actually a lot of discussions about the necessity for expanding the data, but it goes beyond the sort of expanding the availability of data. It goes to the change in mindset. The data are not a luxury in cancer control programs, but data are an asset. And in many jurisdictions, when we ask for more data, the answer that we get is we don't have the resources, we don't have the people to collect the information, we don't have the money to put into the data collection. So if we change the mindset that data is not an expense, it's an asset. It's an asset that's necessary for planning. Otherwise, national cancer control plans are guided by blindness and imagination rather than by facts. The other issue that we have in the data is availability of data even when they exist. So in a number of high-income countries, there's a lot of data on the cancer. The data doesn't always get back to the providers right away, to the level facility level. And also the data is obtained too late. So cancer registry data is usually collected and cleaned and available 2 to 3 years later, which is great for research and for analysis, but it's not that good for planning your next year's performance. So I just like to add a few words and then give opportunity for Felicia to chime in on the data subject.
I totally agree. And furthermore, not investing means having the wrong data or very poor data. And so the best case scenario there is neglect, but the worst case scenario is doing the wrong thing. So the point of my presentation was that by not internalizing within our data collection the value to human beings as well as the value to economies of investing in cancer, we're making all the wrong decisions about our investment. A short-sighted investment plan is really not the smartest way to do things. And you'd never do it if you were thinking about your own financial health or if you're a minister of finance. So why are we doing it on health or on cancer sometimes just confuses me. We have to apply the same kind of wisdom that we do for economic modeling to investing in something as important as cancer.
I'd just like to add a little bit to what Mary just said about the importance of data. I completely agree with you, Mary, that data is an asset and should be looked at as one. But I also realize the challenges that we face in low-middle income countries. And when you're constantly firefighting to ensure that you're able to provide the best possible care, collecting data somehow takes lower priority. And I think this is where I think we should look at technology to be the game changer here. And there's enough evidence now that if you use innovative methods to collect data, going beyond the traditional ways of a doctor or a paramedic entering data into an electronic medical record, and look at ways that the way this conversation can get completely transcribed into a summary which is ready for analytics. We should look at data entry in a similar way, and I think it will be a lost opportunity if we don't do that. And I think the time is ripe because the way AI and ML are moving along, personally, I would be disappointed if we were to have a similar conversation 5 years from now.
Can I just a shout out to patients and families? Maybe it used to be hard to have voice, but it's not that hard anymore. So I'm asking you to share your concerns, to speak about your journeys, and for us to then figure out ways that we can harness that information and turn it into evidence. But the quieter you are, the less we know. And that's obviously a particular message to those who are disenfranchised from voice. And we're speaking about children, we're speaking about women, we're speaking about the poor.
We have another question, Marcella, from Ajay Agarwal, which is interesting.
Yes, he asked, what extent can international health systems then benchmarking play a role in influencing policy within individual countries, and complement with what is the potential for knowledge translation and what may be the barriers?
Who wants to start, Pramesh?
Ajay was at the Tata Memorial Hospital this morning, and a part of his question is related to that. And I think it's an extremely important aspect of what we are looking at, because getting data is one thing. What you do with the data is entirely another. You could just use the data to just give those fancy graphs and pie charts. But the more important part of that is that you could also use it to benchmark yourself and use quality metrics to improve and make sure that it's not just used to project or predict for what is happening before, but also look backwards and identify those areas of your own institution or your health system's work which can improve the overall quality of care. And I think the realization that quality and safety of patient care that we are able to offer is something that's extremely under emphasized, especially in low-middle income countries where, again, you're firefighting and you don't pay enough attention to your benchmarking. So I think it's an extremely important part of using the data that you would use.
I'd like to add to that, and put a shout out to the International Cancer Benchmarking Partnership, which, as Ajay knows, is a project by a number of mostly high-income countries with similar health systems, looking at outcomes, very specific outcomes in specific cancers, and comparison. They've published a number of papers, one comparing the outcomes in different countries, which certainly in Canada, when the outcomes were published according to provinces, really generated some discussion of why outcomes, for example, in lung cancer, ovarian cancer, are different in different provinces within the same healthcare system. And the other paper that they published that showed actually that although there are differences in outcomes between the countries, everybody is doing better over time. So I think that the international benchmarking is very important. There is some evidence that it can spearhead some action, probably not enough. I think Ajay probably can answer how it affected the cancer system in the UK. But I think doing more of internal and external benchmarking is a good idea.
You know,
Oh, sorry. Go ahead, Felicia. Sorry.
go ahead. You go ahead, Pramesh.
No, I just wanted to check if Ajay was available and free to respond to that.
I think he can only respond in the text, can he? Actually,
Yeah,
Yes,
he can.
you can only mention some things in chat.
keep writing tests and we will share. In the meantime, I think that point about benchmarking at the subnational level is incredibly important. So, I mean, we've seen cases in Mexico historically where monitoring across states was incredibly effective at evoking change. I think the key, though, is you have to keep it up. It's not enough to say things are no good at a point in time. You have to be able to show how some get better and some don't, and analyze why, and use that, and where possible, you know, link it to budgetary allocations. On the cancer-specific question, I think the issue is, are we actually in the benchmarking or not?
Thank you very much for your answer, Felicia, as well. So we have reached the end of our hour for this panel. I don't know if you have time to answer the last question, or we can comment in the chat.
By Tatiana?
Yes, she's just adding who should be, who should invest in data collection, even informative research.
So can I just give a positive response in what is a very unusually complicated global political environment around research and evidence? And I think the positive response I'd like to give is, look what St. Jude's is doing. If you had said to me 10 years ago that it was going to be a private hospital based in Memphis that was going to drive change around children's cancer globally, I probably would have laughed. And it is the truth. So there is so much that can be done individually with particular institutions. I'll let Pramesh say how the grid has done that. But I think the answer that we have to go to is there's a tremendous amount that we can do individually and as institutions, because we have access to these data. But I think, Pramesh, I think your example from Tata is really very important.
No, I can't agree more with you, Felicia. And again, the one single message that I would have is that you can achieve so much as a group, much more than you can do as individual organizations. And I think we need a conceptual mind shift from what we've been used to. So as premier cancer centers in the world, leaders of cancer centers want their own cancer center to be the best cancer center in the world. MD Anderson wants to be the best cancer center in the world. Princess Margaret wants to be the same. Tata Memorial wants to be the same. University of Miami wants to be the same. If we could go beyond that mindset and think that if we were to truly be the best cancer center in the world, you need to not just get your benchmarks up, but also enable and empower the rest of the world to catch up with you and actually narrow the gap. Completely contrary to the philosophy that most leaders have, that they should increase the gap between themselves and the next leading cancer center. If we could get over the mind block that you could actually improve as well as reduce the gap between yourselves and the next cancer center, that would be a huge service that we would do to mankind.
Thank you very much for that, and thank you all for joining us today and for your valuable contribution to this discussion. I think it was an honor for all of us to share this space with you as experts and also advocates. So we thank you again, and we will continue sharing our efforts, and more is coming for our commission. So thank you very much.
Thank you all.
Thank you.
Thank you.
Bye.
And watch out for the commission. It's going to be awesome.
More is coming.
It is.